Dr. Mohanty, thank you. That was wonderful, really fantastic talk. I believe there are a lot of questions today. This is a very common problem, and so I would ask our audience to raise their hands if you have any questions. In the meanwhile, I'm going to start with one question. You mentioned the patients with obstructed bile duct or undrained bile duct. TRIPS is a relative contraindication. So especially PSC patient coming with portal hypertension, what's your take on those patients? Is how cautiously we should do at TIPS in these kind of patients?
My understanding is that we do stent. I mean, in the 2 cases that I have seen, we do stent that bile duct, or at least try stenting it before going on to do TIPS, because a bile duct obstruction is another form of liver dysfunction, and I think the first. But you should remember that the patient is very sick, and a case-by-case basis determination is necessary. Sometimes, you have to make a decision on whether this patient is going to die from this variceal bleed, and then we go ahead with the TIPS. But the attempt is to stent it before, or very close to the TIPS.
Thank you. And also, there are a couple of other, I want to understand, especially age. You mentioned age more than 75, and we do see some issues with this kind of patients when you do TIPS, especially for indication like ascites, refractory ascites, not for variceal bleeding, although it didn't touch a lot on that part. But if I can ask that questions to you, why would you not consider in older patients, and what would be the risks with that?
The main reason for that, when we put forth recommendations, I think there is a lot of review of data, right? And the current data is just, the studies just do not involve these patients, so we do not know what would happen with them. And that is the main reason why that age is put in there. But recent studies, I think there is a retrospective study that has shown that TIPS may actually, patients above the age of 70, and most of them were below 75, actually do fine with TIPS, and this may be a good intervention for actually their quality of life. It can actually be prevent hospitalizations and keep them outside hospitals. So it should definitely be considered on a case-by-case basis.
Right. We have a few questions from the audience. It seems like we can go over some of this. First of all, Dr. Adil Menon saying this is a extremely helpful talk. Working as a liver hospitalist as Osner, we just had a patient who had an 80-year-old is getting TIPS this AM. I'll hopefully be able to join next session, but he's complimenting your talk and thanking for this very super nice talk. There's a question from Dr. Misra, how to approach an actively bleeding duodenal varix. You briefly touched on it, but can you just elaborate on this?
Yeah. So actively bleeding duodenal varix. The bands typically will not stay on them, but can be considered on a case-by-case basis. Most of us have a good idea on what type of varices the band will go and stay, by looking at them. I have clipped a duodenal varix and called for help because I am not very good with the cyanoacrylate injections. And then we have injected them to acutely stop the bleeding. But thereafter, the next step would be to get contrast-enhanced imaging, a CT scan, to see what the feeding vessel is and plan a definitive treatment. In my practice, that is a transvenous obliteration, a ATO or a RTO. But in other practices, especially in India, I hear that very good endoscopic management of varices can be performed, but I have limited experience in that.
We can ask some of our expert from India. Dr. Dharmesh Kapoor is there, as prominent hepatologist. Yeah. Dr. Kapoor, if you can share your experience and any thoughts around this.
Very nice talk. Thanks for that. So I think you've raised some contentious indications, and I would like again some elaborate remarks on the same. Patients who are high acuity, especially GI bleed in the context of patients who have acute on chronic liver failure, wherein even the Baveno guidelines tells you that you can throw caution to winds, and even if the patient is encephalopathic, you might want to consider them for a preemptive tips. And earlier literature used to suggest a cutoff MELD, but like you said, that we would probably go with the Child-Pugh scores in this. Again, something that can be argued about because Child-Pugh score remains very subjective, So
Yes.
what are your thoughts on that? And I think, first this question, and then I'll tell you probably what is lacking in the TIPS literature, because this is a procedure that has been going on for decades on it. But still, everybody keeps talking about the procedure per se and the refinements thereof, rather than what happens to these patients over a period of time.
Yeah. So I think I'll try to answer some of them. You're right that things, the data to support the use of preemptive tips, there remains debate about that. But the combination of the data, I mean, that is of all the recommendations that I gave, I can say that is the one that is backed by robust randomized controlled trials, at least 3 of them. And when put together, most patients were either child C 10 to 13 or B 8 to 9 with active bleeding, right? The incidence of hepatic encephalopathy was not high post-TIPS in them. And that makes me confident that this can be this is a strong recommendation that TIPS can be used in patients without the risk of encephalopathy in patients who meet that criteria. Now, the patient who keeps coming to the hospital before with overt encephalopathy, the one that we are trying rifaximin and lactulose and really educating the family and really taking time to keep them outside the hospital, may not be the best candidate. But the patient who just GI bled and is obtunded because of that blood in their stomach is a candidate for preemptive TIPS. And that is my understanding and practice, supported by high quality evidence, actually.
See, the issue is that, these statements are almost always associated with the rider that you should consider these patients for a transplant in the short term, but that's easier said than done. For example, if you have someone who's got acute on chronic liver failure and presents with the bleed, and you take him for endoscopy and you see that this patient's score is going to be quite high, and if you see a spurter child. So the problem is that these studies were designed in an era when we had stopped using Child-Pugh. So I agree with your statement that these are randomized controlled trials, but this is a kind of a regressive step, So why would you want to go back from MELD to Child-Pugh? And these trials are all recent trials. So these are not trials which were done long ago. And there you again start to go back to Child-Pugh and see that if there is a bleeder with a score of 7, 8 or a C but less than 14, 15, then you would want to do a TIPS for this. So I think it's a little difficult to wrap your head around this, because and I think probably what these studies might not be mentioning in the fine print is that you are just introducing a shunt, not necessarily something that has been dilated, and which we know that it works wonderfully well in patients who are high acuity or patients who got a slightly iffy heart and probably are not dilating the stent at all. And there is just a conduit which acts as a bypass. So it's a little difficult to understand as to how in a very, very sick patient, because the traditional teaching was that even if someone has got a bilirubin of more than 5, you should not be doing a TIPS on these patients. But now
I agree. I agree with your comments, but that MELD of 15 comes from a very different era, from a different study, and it cannot be extrapolated to these TIP studies, and that is why MELD should not be used. And in my practice, actually, a TIPS is a good, most of my patients, and that is actually American practice, even if they are listed for transplant, most of them will not get a transplant. And in the type of, I'm a general hepatologist in practice, although I trained as a transplant hepatologist. By definition, all my patients are not going to get a transplant. So TIPS is a very good way in these selected patients to buy them that time. And of course, you know, if you feel that your patient, like with ACLF, with high MELD, 14, 15 Child-Pugh, you know, that there is a significant role of palliative care in this option. This might be the event that is the beginning of the end for many of these patients. And then that remains true.
Thank you.
Great, thank you. Yeah, thank you.
We have a few other questions. Dr. Mubin Khan, Dr. Khan.
Good morning, everyone. And that was a great talk. I had one comment and then a question. Comment was I had, since we talked about the TIPS in elderly, we actually looked at this in National Inpatient Sample Database in last DDW. And what we showed was there is increased risk. This is a sample database where we looked at 65, less than 65 and 65 to 80 age group. And then it did show some increased mortality with odds ratio of 1.78. And on the multivariable analysis, as we all expected, the cardiac issues stood out as risk factors for increased mortality. So the evidence, there is evidence, but obviously it's a sample database with its own caveats. Now the question is, I know we're talking about MELD, and then you did mention about there is no MELD cutoff, but in practice, real life, and I can be corrected here, we still rely on the MELD, though. We still, if somebody with a MELD of 25, 26, compared to somebody who's MELD of 18, 19, we do risk stratify. And Child-Pugh, to Dr. Kapoor's point, since it's a subjectiveness is involved, so we still go with objective metrics. But I'd like to hear from the experts here, if they consider MELD. I thought in real life we still look for MELD. Thank
you. You know, the MELD, the main reason to mention MELD was that cutoff of 15 of MELD that we traditionally used to use for TIPS does not really apply here in variceal bleeding, that you can perform it in much sicker patients. But yes, if you know, the 25 cutoff that you mentioned also is arbitrary. I don't think that it is supported by any evidence. But the bottom line is that if your patient is very sick, you know, TIPS and transplant is not an option, then TIPS is also not an option. And that's the only thing. You know, earlier, the reason that I mentioned the MELD mostly is because we would get pushback for preemptive TIPS saying that, okay, the MELD is 20 right now. And the MELD can become 20 in this patient who just presented with variceal hemorrhage. And they are like, we won't do it. And that has been refuted. And, you know, a comment about the Child-Pugh is that, you know, the TIPS is greatly, especially when you have gastro-fundal varices, you know, the decision for TIPS is also influenced greatly by the presence of ascites. And, you know, when I have a patient with ascites, I really want to find a way to get them the TIPS to hit, like, to get two birds with a stone. It improves their quality of life, potentially prevents this, like this titration of diuretics and this renal failure thing that you deal with refractory ascites. So, you know, the subjective part exists for encephalopathy and ascites, I agree. But that is why I made some clarifications about encephalopathy and the MELD also. You know, that is the evidence. And you know, I keep telling our fellows that, you know, these are not written in stone. It is for us to judge how we use them. These are just guidances. You know, what can I say? These are, it is not the rule of law. It is to guide our decision making, and all of you are probably correct in your decision. And about the national inpatient sample, we can only look at like in-hospital mortality, right? So I take that with a grain of salt. But, you know, if your 80-year-old patient is bleeding out and is Child-Pugh B, okay, I would go for a TIPS. I would think about that. Yes. Dr. Ravindran?
Dr. Mohanty, thank you for the talk. My question is, do you see a role for splenic embolization in patients who cannot have a TIPS?
We did not comment on that in this. So when are you thinking of? What is the context that you're thinking of splenic embolization?
So, I mean, I haven't had a situation lately. I had a 79-year-old with like recurrent ascites. He also had varices as well, and like I was nervous like putting a tips in somebody 79. He had coronary artery disease but no heart failure or anything. And like I asked around my colleagues, and like the recommendation from everybody was like not to proceed with the tips. So I was thinking like what else I had to offer him.
So the patient had variceal hemorrhage, or was it just ascites?
He had high risk varices. He had like red
High
vein
risk
sign.
varices. Yeah, if it is just esophageal, I would ban them, right? And for gastric, I wouldn't touch them. I mean, if you say that you're seeing these red veil signs and they're going to burst, I have looked at the data ad nauseum and I can't figure it out. But if you really want to embolize them, you can embolize gastric varices directly without touching the spleen. Because I would think that if you embolize the splenic vein, right, like you would get a lot of increase in your ascites, because you really have blocked it now, and I would think your ascites will worsen. So it may not be such a great idea.
Do you see a role for splenic embolization in any other category of patients that they can't have a TIPS?
Well, we have reached, for variceal hemorrhage and varices, right? We have reached a point where we are able to access most varices very specifically. So the role to just embolize the spleen is low, and I have not seen any literature for that. If there is, let's say, the anatomy really does not favor embolizing any varix, okay, maybe splenic embolization can be considered, but I really have not seen any literature in an extensive search for this to support that.
Thank you.
Thank you. I think I have a question from Dr. Roxana Begum. Dr. Begum, you want to ask your question and introduce yourself as well? Dr. Roxana Begum.
I am Dr. Roxana Begum from Bangladesh, and I am Assistant Professor of Hepatology working at Shoisowardi Medical College Hospital in Dhaka.
Yes, I think your question is that whether we can ban ligate rectal varices, right?
Yep, that
So
looks like the question.
Yeah.
Yes.
In the bleeding rectal varices, to control bleeding, I have banded them, but I always follow it up with cross-sectional imaging to see what is the flow in those varices. And the repeat banding just may not be practical in very high flow systems. And then we either embolize them or plus minus put a TIPS with them.
Okay, thank you.
Thank you. Dr. Maliakal from Nashville.
Yeah, hi. I have several questions and a comment. I think the previous caller was talking about proximal splenic arterial embolization, which has been used for both ascites and varices with some good effect, though there are no large studies. That's one.
Okay.
Second thing is, the problem with MELD, MELD sodium, MELD 3.0 in situations is if the MELD is due to sodium or creatinine or low albumin, those things are not going to affect the mortality related to TIPS directly. Whereas if it is bilirubin and coags, so we may have to do a different scoring like they do for heart, like when they do heart transplant in cirrhosis or liver disease. So we may have to come up with a different score. And the other thing is in alcoholic hepatitis, if they have acute GI bleed, I think we have all done TIPS in patients with over MELD of 30, and they seem to do okay because, you don't have a choice, but we've seen retrospectively that there are people who recover quite nicely and the alcoholic hepatitis goes away. And then those are my comments. My question is, especially in alcohol and other certain situations where there's reversibility of liver disease or liver function, do you decrease the size of the tips or occlude them down the road 2-3 years after the tips?
No, actually, they seem to do fine, like the body recalibrates, and let's say they don't drink, we're talking about recompensation here, and see, the evidence for all that is very little. But in my experience, they do fine even with the tips in there because their liver has recovered. Once the liver recovers, when your albumin is above 3.8, 4, I think they all do fine, even if they have a tips.
Do you still follow them with ultrasound, or you just let them go?
I do follow them with ultrasound. One of the things is that patients who have alcoholic hepatitis, right? I would say literature has shown that 90% of them actually have cirrhosis. So our HCC data is all very iffy, right? Like we don't know whether the ultrasound is the best, and we don't know how many times, how long, which etiology. So I do follow them. I do not let for the HCC thing, and then it is very easy to add on the Doppler.
Yeah, I had a recent patient who had refractory ascites and she was alcoholic, and I did a TIPS, and she's now, her liver functions are completely normal. Everything, you wouldn't even know she had liver disease.
Yeah.
And we did a Doppler, and the Doppler said, oh, the TIPS is, narrowed and occluded. You should consider, dilating it. And of course, I'm not going to dilate it, but this is a situation where you just allow the tips to kind of.
Yeah, this has happened to me. Yes, I agree with you. I have also let it go, and the patient is doing very well. Typically, younger patients who really stop alcohol, they can do wonders. But if in my patient, I had put it for really bad ascites, like really ascites that I couldn't control at all, with multiple episodes of SBP, and she's doing well. I know what you're talking about.
But what if the same patient has recurrent episodes of encephalopathy now?
So why would they? If you really have recovered from alcoholic hepatitis and your albumin has come up, I very rarely, I think I've only seen one case of patient with encephalopathy with normal albumin. As you develop your muscle mass, as you develop your nutritional status, I would be very surprised if your patient has recurrent encephalopathy. And if they do, if you have exhausted everything, I would go for downsizing that tips. But I would find that very, very unusual.
And that brings me to another comment about, there's this theory that high ammonia levels, cause muscles not to, they're like increase myostatin and other things. And I always see patients who are pretty malnourished do well after tips and have better muscle. So I don't think the ammonia hypothesis for sarcopenia does hold all the time. There's something more to it.
Yeah, I feel anecdotally, the younger alcohol-related hepatitis/cirrhosis patient who really quits alcohol does well. In my practice, we have a good nutritionist, and we really fatten them up, like with multiple protein strategies. We have a food pantry. We give them lots of high protein canned tuna, like things that they can afford and eat. As we plan, as we see ascites or as we plan tips. And I feel like once you improve their nutritional status, you'll get better.
Thank you.
Thank you, Ben. Those are great discussions. And actually, I'll support you. We just had an abstract published in AASLD looking into the various components of the MELD score, 68 patients who had tips done, and we looked at the bilirubin, the effect of the individual components of the MELD score and its impact on survival. And truly, bilirubin and INR mattered much. The creatinine did not matter. So I think you are right that we need to revisit into this MELD as a whole, as a predictors for survival, rather than having maybe a different scoring system for it even in the future.
So Sanjay, can I make a quick point before this audience leaves with a wrong notion? So, you must draw a line here, and obviously, I don't think it's true to say that creatinine does not matter in these patients. So let's slightly digress from this point and not talk about the patient who's presented with variceal hemorrhage for the first time in a startling manner. And supposing
Yes.
you were to perform TIPS on a patient with the refractory ascites and a creatinine of 2, you think that's a good idea? So I think what you are talking of is just data, random data collated together. All right.
Well,
so I don't think in your cohort, it's a pure cohort of only patients who've been tipsed for a variceal hemorrhage. So someone who's got a refractory ascites and a creatinine of 2, I
you
would
are
be
right.
very averse. Yeah.
You
I
are right.
think we just, we can't generalize the statement. So what I had said earlier, Dr. Mohanty, the data which is lacking in published literature, and I know you wrote the guidelines, is that people who get a TIPS done for refractory ascites, they will have, and it's a well-performing TIPS in the sense that the control of ascites has happened. And like Dr. Maliakal said, that they put on a lot of weight, which is probably because they were losing it by way of high protein ascites drainage from time to time, not necessarily the ammonia story, because again, that will just draw this discussion to another level. So I think what happens to their liver functions over a period of time?
So after patients with refractory ascites have got a
Yes,
TIP?
yes. Yeah, refractory ascites treated with TIPS with good control of ascites. So when you follow them over a period of time, so the initial results are very gratifying because you've done it for a specific indication like a refractory ascites or a hydrothorax. But what happens to these patients when you follow them up over a period of time? So is there a dip in their liver function or do they remain the same?
Well, it really, it also depends upon other factors also. Like we were talking about the etiology of the cirrhosis, whether the nutritional status is optimized, whether they had cirrhotic cardiomyopathy to begin with. And I have seen all combinations of that. I have seen liver function worsen, albumin remain at 2, and then we're like struggling really badly on what to do. I have seen them improve greatly, to the point that they are completely off diuretics, TIPS is working, they don't need transplant, nothing. So it really depends upon the combination of that patient, and in only one thing such as the MELD score or just the etiology, it's very hard to determine that, answer that question in that way.
Dr.
Right,
Kapoor,
because you yourself, you mentioned a number of times in your talk that you're diverting blood away from the liver. So, if from the pathophysiologic mechanism you were to look at this situation, there would be a slight deterioration over a period of time. So clinically, they might not be very unwell, but one would suspect that there would be some degree of, liver dysfunction, for want of a better word, in them over a period of time, because indeed you are diverting blood away from the liver.
We know that the bili rises up a little bit and the INR also rises up a little bit after TIPS, and it is seen in the ensuing few months after the TIPS.
Yeah.
I think this is where, sorry.
No, go ahead.
I think this is where the bridge to transplant versus destination TIPS, I use that term, destination TIPS, is worth looking at, because if you do a TIPS on a young person with refractory ascites, that person may be disadvantaged down the road in terms of getting liver transplant, because they lose the sodium and the creatinine effect, and they have to rely on bilirubin and INR alone. And so they might be disadvantaged.
I think that's a good question to answer, but it will be difficult with the, I think there is a lot of push towards transplanting alcoholic hepatitis and alcohol-related cirrhosis now, and it will be difficult to study because if your patient really is eligible for transplant young, otherwise heart is okay and everything, you should go for transplant, you should transfer him. And we'll never know the answer to the destination versus transplant.
Dr. Kapoor, I want to make...
Dr. Mohanty, I'm very sorry. This is becoming a very engaging conversation. You mentioned that you would never advise primary prophylaxis for gastric varices, and I'm so glad you did, because in the country that I practice, this seems to be a very fashionable thing to do. So what are your thoughts on the use of non-selective beta blockers as primary prophylaxis for gastric varices?
I do put them on that, but I also know that gastric varices can TIPS works for most gastric varices, right? But some of them will still have some weird flow, right? Some weird feeding vessels which the TIPS does not decompress. But I do not. The risk of bleeding from from gastric varices, initial bleeding is way more lower than esophageal variceal bleeding. I do put them on beta blockers, but I do not do any endovascular therapy for them. I did look this up because I knew that my audience will be Indian. I looked up all papers for primary prophylaxis last night, just in case this question was asked.
You know, there are two groups of patients, right, Dr. Kapoor? Like one group is this variceal bleeding, another is the refractory ascites. And when you go to the radiologist and ask them, oh, I need a tips in this patient for refractory ascites, the pushback is this MELD cutoff many times. You know, many centers still do that, and our radiologists do. With these guidelines that came up now for the variceal bleeding, we know that, you know, there is no MELD cutoff. So that's great. But for the ascites, the elective cases, they still continue to give a pushback with a higher MELD score. And that's where my point was, creatinine should not be a contraindication for these patients to, you know, not to allow them having a TIPS, because in fact, the kidney function improves in many of these patients over time. So that's what the point I wanted to make. I have Dr. Prasoon Jalal, who's still silent. Dr. Jalal, please.
No, that's a great talk and great discussion. Thank you. Well, you know, the problem is the TIPS is effective and we're using it for many years, but the literature hasn't progressed that much. We go with our own experience and conviction. And in every center, our center also for, you can call it secondary prevention of variceal hemorrhage, or otherwise our radiologists give a little pushback. If you want to do TIPS in patients MELD more than 20 or bilirubin, they have a cutoff bilirubin of 3. So they're worried about liver dysfunction. Now, don't get me wrong, that for any patient who has go rescue TIPS or patient is bleeding, I push the radiologist to do TIPS no matter what. So even last week, I had a patient, MELD score of 40, patient is actively bleeding, and I pushed the radiologist to do a TIPS. So I don't know. I think we need to work on this literature a little bit. The guidance is definitely helpful, but as everyone mentioned, the Child-Pugh C is a little difficult for us to that way, especially if the patient has ascites, they will have Child-Pugh C. So this bilirubin cutoff is arbitrarily used. I don't know there's any data to support that, but maybe we should have some literature ourselves to develop. Now, coming back to the previous comments, partial splenic embolization, actually, it's not an easy procedure, but it's arterial embolization of the spleen, definitely helpful to reduce the flow in the gastric varices, and it has been used. And there are case series and case reports, but people haven't used in this country very much. My question is mostly about, you did mention about using primary prophylaxis of HE post-TIPS encephalopathy with refractory lactulose. I personally don't do it. I know there was the article published in Annals of Internal Medicine which showed that. I know that people have replicated it, and I also don't believe that we should be doing, again, it's my belief, not necessarily evidence-based, doing routine post-TIPS ultrasound Doppler. What difference does it make? I mean, how often we get restenosis like older days? So if 20-30% getting HE, why you want to randomize everybody? Why you want to put everybody on rifaximin or lactulose if they didn't have an HE or they won't develop an HE? And why do you want to propose we need to periodically ultrasound Doppler them? If there is real indication, of course, if it's suspected stenosis, fine. But why do you want to do that?
Yeah. So you say, I may argue the same thing that you're arguing, right? You're like 50% of patients will not get HE, but I may argue that 50% will actually get HE, and that is a huge number. And for that reason, it might be worthwhile to surveil the TIPS. Also, the effect, like let's say the chances of TIPS dysfunction are low. That's your argument, right? It's there's no TIPS dysfunction in 90% of the patients at 1 year. but the consequences in that 10% are very high because they will have another life-threatening bleed. Okay, so that's why TIP surveillance at 1 to 4 weeks is recommended for that reason. I must tell you that all this is just expert opinion, and we all sort of are more conservative than liberal, and that's how guidance statements are written by the honchos, really. So I am with you, and I, as I mentioned again, that these are just guidance statements. They are for you to judge how to use in your practice. Some of them have stronger evidence, such as the tips, okay, the preemptive tips, I think. But the rest of it, you know, I personally don't surveil them that frequently. If they don't have any symptoms and they have recovered from variceal bleeding, and it is like 1 year later, it is very, very unlikely anything has happened to that tips if they are just fine and coming to my clinic every 4 to 6 months. So I am with you on that. And I to this audience, I would say that these are just guidance statements. They are meant to inform your practice, not run them.
Thank you.
Yeah.
Thank you. May I ask Dr. James Park? James Park is our chief of hepatology at my center. Dr. Park, your comments and your experience on this, any thoughts with regards to any change in practice with this talk?
Yeah, thank you. Thank you for the comments. I think it's an excellent presentation, very informative and comprehensive, and also a lot of great questions. I think I agree with you that so I think at the end of the day, each and every one of us has to have a individualized approach to each and every case and specific patients. Yes, I think our center, we don't prophylactically treat, you know, gastric varices unless there's a clear indication of bleed. And also comment about splenic artery embolization. Typically, we don't. I think this is a great question. I think more study needs to be done, but because of fear of a potential splenic artery infarct causing sepsis, infectious complication in already decompensated sick patients. So typically we do not pursue that approach, but it is a kind of novel the idea that we need to probably put some more study into it. Thank you. Great presentation. Thank you.
Thank you, James. Any other questions before we close?
Sanjay, I see
Yes.
Dr. Michelle Kim on the audience. If she is
Yes.
there, you know, let's see what she has to say about primary prophylaxis of gastric varices. What's the experience?
Yeah, Dr. Kim, please.
Are you there?
Hi, so I'm not a physician. I'm a nurse practitioner. I'm a new nurse practitioner working with Dr. James Park over at the Liver Center in Manhasset. I don't really have any questions, but in terms of comments, I do feel, because I'm pretty new to the liver field, so I do feel as if this talk on tips, we were just talking about it after clinic on Wednesday, so I feel like it was pretty informative, and it's been very great to hear everyone's opinions on, you know, the different contraindications or indications for the tips procedure. So I appreciate you all for letting me be here this morning.
Thank you. Thank you for joining. Thank you for joining. Okay, by the way, when we're almost at the end of our meeting today, thank you all for joining.
Sanjay, one quick question before
Sure.
we part.
Yeah, I'm not closing. I'm still there.
What are your thoughts on anticoagulation after tips?
Yeah,
that's a great question.
Save the best for the last.
These are like really hard questions, honestly. Okay, anyway. So now, you know, if we see tips dysfunction, I do put them on anticoagulation. Sometimes the radiologist will tell me that the flow is really slow in that tips, and then I will put them on aspirin. But I do not particularly fear anticoagulation in these patients. So if I see really slow flow, or there was one episode of this thrombosis for whatever reason, I do put them on anticoagulation.
Yeah,
So would you put them on an antiplatelet or would you put them on anticoagulant?
So, so with the lack of all evidence, I put them on antiplatelet if there's very slow flow. And if they clotted one time for whatever reason, I would put them on anticoagulation. I truly like warfarin the best because it's the easiest to control if they bleed again.
Dharmesh, our radiologists usually go back in and recanalize the tips.
No, I'm talking actually of just anticoagulation as a prophylaxis after tips. So that's what we do at our center. So we would prophylax them with the heparin and very quickly transition. So we use unfractionated heparin and very quickly transit to low molecular weight heparin while the patient is still in the hospital. And then over a period of few days, we would stop that altogether because by that time, this is a foreign body in a vein. So, you know, if you were just to think about the Warshaw's triad. So I'm not saying there is any hard data, but it doesn't hurt. That's what I was trying to say.
The tip stenosis used to be very common in older.
But those were the bare metal stents days. So
yeah, but with the new ones, I usually rarely see tip stenosis or clot. So I don't think any centers here use any anticoagulation routinely, prophylactically, and I think
I know it's also not been addressed in literature, but it's just that in our country, if there would be a re-intervention needed, it burns a hole in the pocket, not as though the first procedure doesn't. So what I was trying to say is that this really doesn't harm, even if quote unquote your patient is having a raised INR. So of course, which is all something that we all know, but at times we are reluctant to use anticoagulation in steatotics.
I will also argue that there are, my practice in the last 4 years, at least 3 patients have clotted out with the tips with the current the stent that we're using. So it is not uncommon. It does infrequently happens. So
in our unit as a routine, we do anticoagulate them. That will generally be for a period of 2 to 4 weeks, and by that time, the surveillance Dopplers have shown a well and truly established flow pattern. See, the radiologists have a different view on tips dysfunction. So Dr. Mohanty spoke about the stenosis, and she also gave 2 parameters on velocity, which are the extremes. But for a radiologist who's in sync with the reporting on tips Doppler measurements, they're supposed to measure it in the proximal portal vein, just before the tips proximal end, at the portal vein in the middle, the tips in the middle, and then towards the hepatic vein IVC orifice. So these are the 3 measurements which they keep talking about. And I'm sure Dr. Mohanty knows, and I have not read the guidance document that they have written, but probably the radiologists always swear by that. But we don't bring it into practice. So for me, a very simple thing is that, for me, a very simple thing which
come from. What you are saying, it was the radiologist's recommendation. Yes.
So I think what we tell our fellows is that you don't even need to call a radiologist. So if you put a tips in the right hepatic vein, right branch of portal vein, which is generally the commonest practice, you just see what the flow is like in the left branch of portal vein, and if it is fugal, then you are okay. So you don't need to, so that's a very simple thing.
I had a slide for that. I just thought I wouldn't add it for the sake of time. You're absolutely right. Yes.
I have a quick question to all the experts. After the RTOs, VRTO, ATO, whatever, do you see anybody has clinically significant esophageal variceal bleed in your experience?
Yes.
Obviously, we all know the pressure goes up. So what do? Do you ban them prophylactically?
Yes.
I ban them all.
Yeah, the same.
We do the same just to make sure. I think in this AASLD, there was from AIMS, right? They in the plenary, they presented some data from Shalimar. I know I was visiting AIMS and they were working on it. I think they had some data presented. We have to look at the exact thing which they presented, that they showed it's significantly going up the pressure and the collaterals. So this part may be another area we need to also look into and need to educate people after the radiological intervention.
One other question that was not addressed is, I think there is some literature earlier with tips for portal vein thrombosis and anticoagulation with that. So, Arpan, you want to comment on that?
Yeah. So, there was in 2018, right, in the first AASLD debate, when I was still a fellow, that was the topic of debate. And I spent 30 minutes saying why we should anticoagulate, and there were these various arguments, mostly as a bridge to transplant. But but you're asking in tips, right?
Mm-hmm.
Like
No,
tips
no,
as
no.
a treatment for portal vein thrombosis?
Yes.
Yeah. So only for clinically significant portal vein thrombosis, such as an acute portal vein thrombosis, in which patient presents with abdominal pain, if the thrombosis is extending very far into the superior mesenteric, splenic, and has significant downstream effects, then I would consider it. But if it is a small, the extent of portal vein thrombosis is not long. Data says that in cirrhosis, because of this Verscha's triad that you were talking about, right? The small thrombosis may actually just go away if you keep following the patient in 30% of the cases. And it is a natural course of the illness, one may argue. But I also had presented all this data on primary anticoagulation for cirrhosis and talked about parenchymal extinction and whatnot. So I believe we can take that on a case-by-case basis. But for acute portal vein thrombosis and extensive portal vein thrombosis in a transplant candidate, I consider TIPS very strongly.
Sanjay, too, I agree. So number one is obviously, as said, Arpan mentioned that, but TIPS can be therapeutic in patient with, significant portal vein thrombosis if it is persistent. Number one, and number two, recently we have few patients. I mean, I was pushing our radiologists to do it, but we did PVR TIPS, because patients comes with intractable bleed. So portal vein recolonization and then TIPS. So again, TIPS can be therapeutic in patients with portal vein thrombosis. So thrombus will, because you're correcting the flow.
I think there is, also possible hypercoagulable state. I mean, like in Budd-Chiari, for example, if you do TIPS, you'll still continue. And so there may be some people who get post-TIPS thrombosis, they may have factor V Leiden or some other factor that might be involved. And the other thing is, this is the reason why you should occlude all other large collaterals when you do a TIPS, because that way the flow will be directed through the TIPS, and that one arm of the Virchow's triad will also be helped.
All right, we are 4 minutes past our time. This is great, engaging discussion. I think we got a lot of important points out of this talk today. This talk, with your permission, Dr. Mohanty, will be on the website, so people can go back and listen to the talk, and any comments, please share with us. And I would like to thank you again, Dr. Mohanty, for coming in today. This was fantastic.
Thank you.
Great.
Thank you.
Thank you.
Thanks.
Bye-bye.